Right. I just want to welcome everybody and thank you so much for joining us today. Today you've come into session 6.1 and it's called Engaging with Patient and Families. I would like to remind you that this is a virtual conference session that's been hosted by the IFIC, which is currently a 3-day conference in Flanders. The speakers today for today's session are Andrea Belanger, Hayley Crooks, Alaa Dayekh, Lhara Mullins, Riordan, and Angela Morin. We're going to start off with some pre-recorded videos of all of the speakers, and you're going to hear all of the presentations first, and then we're going to have some questions at the end. We would advise you to use your portal if possible. If you could put in some questions that we could gather and share to ask the panelists afterwards. This is very much about engaging with patients and families. This is the core. This is the core of why we are all in health and community care. I really am passionate about this topic, and I am delighted to be hosting it today on behalf of IFIC. My name is Susan Kent. I'm Dr. Susan Kent. I'm currently in Dublin City University in Dublin, and my profile and biography are available for anybody there to read, as are all of the speakers. We won't be introducing them, so you can read them as you're going along, as you can read their abstracts for their presentations on the portal. One of the things I do when I don't ask for a biography is that I ask for some little sort of nuggets of wisdom or nuggets about the personality of the person. So in return, I was asked about mine, and my little passion that I would like to do is to drive a Formula 1 car in Silverstone, or actually Le Mans or somewhere like that. Like, I'd like to drive a fast car. So that's my passion. We are very much assisted today by our technology assistant, who is Darren, and Darren is in Flanders, but he is from Ireland. He's from Kerry, and he's from a beautiful part called Valentia Island down in Kerry. So thank you, Darren, for all of your support here today. Now, our first speaker isn't here at the moment, but she does live in Dubai, so it might be something to do with some time issues over there. But we're going to proceed with her presentation, and she may possibly join us before the end of the session. Her name is Alaa Dayekh, and Alaa's presentation will be the first to commence the session today. So please enjoy, and please do enter some questions into the live Q&A, and we'll pick them up and ask at the end to the panelists. And thank you very much. Thank you, Darren.
Thank you, Doctor. So hello, everyone. I'm Alaa. I'll be discussing the methodology of patient engagement through focus teams with the patient and their families. It's for the purpose of maximizing the integrated care healthcare system. So we're going to go through the introduction, the methodology, results, and the conclusion. So as a start, quality by definition is the patient judgment about the healthcare services, but when decisions are made, patients are being out of the picture in the whole quality improvement process. Adding to that, 1 in every 10 patients are harmed while receiving hospital care. That is why patients, providers, leaders, researchers, and policymakers all agree that when engaging patients and their families, it leads to a safer care. So the patient partnership project equation is as follows. The patient and the family member as a valued underutilized resource with valuable experiential knowledge, along with the multidisciplinary healthcare professionals with their academic and professional knowledge. They all brought a new dimension and thinking into the professional team, a way of quality management methodologies implementation. So it's an innovative approach that is highly different from the traditional quality improvement projects. So what is a patient partnership? It's a collaborative relationship that is based on knowledge, skills, and motivations of both parties within the team, which is built on trust, equity, and understanding through the active participation in decision-making process. Through the literature, patient partnership has been focused on in several countries around the world, mainly in the USA, Canada, France, Australia, and the United Kingdom. All these studies focus on the importance of patient engagement, and they have statistically proven the effectiveness of this methodology. For example, in Canada, a study researched that 60% of the disease, there was a decrease in 60% of medication errors, 25% decrease in infection rates, and 8% increase in the nurse's time, and so along in the other literatures. For our methodology in this project, we've initiated the Patient and Family Partnership Committee by first posting an awareness video online. It was the period of COVID-19 pandemic, so we couldn't actually provide direct interactive training. That's why we've used our social media platforms. So when we post the awareness video, some of the patients spread their willingness to participate. There was a strictly eligibility criteria to involve the patient and their families. Mainly, the eligibility criteria was having chronic illness, having long-term experience with their disease and hospitalization, have the will and the proper initiative to participate in and time for sure to participate in such meetings. And then we've provided an individualized training programs for the selected patient and family partners. The training programs were mainly on the quality improvement methodologies, some terminology, some medical terminology even, in order to ensure the mutual understanding within the meeting. Along that, we've announced the healthcare professionals' participations for this project. We've also included a specific eligibility criteria for the healthcare professionals, mainly having 2 years of experience, are engaged in previous safety and quality projects, and also have the will and the time and the availability to participate in such projects. So we've selected the healthcare professionals among the frontline workers and up to the top managers, and for sure 40% of the participants were the majority were nurses. So we've provided also a training mainly about the patient partnership methodology. And then we've initiated the Patient Partnership Committee meetings. It was focus group meetings. There were 3 topics actually: the hand hygiene compliance by the healthcare professionals, the violence prevention program within the healthcare setting, and the conversation time with patient enhancement. And most of the participants, both the patient partners and the healthcare professional, chose to enhance the conversation time and the education for the patients. After the meetings, we've evaluated the effectiveness of those meetings. We then generate dashboards based on those evaluations, and we've initiated the quality improvement plan cycle, taking into consideration the corrective areas for improvement that the patients recommended. And then after implementing those corrective action, we followed up with the participants, and the cycle for this particular quality improvement project using the Patient and Family Partnership Committee was finalized. So this is mainly the methodology, and it's a comprehensive multidisciplinary methodology. So coming to the results, the patient partnership benefits has a trilogy impact for the patient and the partners, for the healthcare professionals, and the overall healthcare system. The patient partners express distress relief, which indicates the better clinical outcome. They've gained new ideas, which is commonly with the healthcare professionals. They felt empowered in decision-making process, and they've expressed enhancement in their hospitalization experience. Actually, a few of the patients stated that finally, through this approach, our voices were heard rather than the traditional approach in patient experience enhancement. For the healthcare professionals, 37% of them stated that they gained a new experience and skills, which refer to the staff development initiatives. They felt frontline workers' empowerment, also referred to the decision-making process. They expressed by this methodology, quality of care can be enhanced to reach high optimal quality care services. And it participants also refer to a safe environment environment, and work-life balance, which refer to the staff well-being. For the healthcare system advantages, 75% of them stated that by using the patient partnership methodology, we're going to reach sustainable quality improvement with no limitation. Almost 50% of them stated that patients can receive their rights through the partnership activities. 53% will guarantee the patient loyalty to the hospital and the enhancement in reputation and the patient experience enhancement, as we said earlier, along to the 85% expressed respect and care provided to the patient through the partnership meetings. So as a result, we were able to prove that patient partnership is statistically significant, where the hand hygiene compliance rate increased from 43% to 74% after implementing the patient partnership project, which is evidence-based practice. For the conclusion and how we're going to reach sustainable patient partnership implementation, we've submit a proposal to the Ministry of Public Health to standardize the patient partnership within the Lebanese accreditation standard. We've changed the St. Georges Hospital vision to include the patient partnership through this strategic plan, and we've recruited a patient and family partnership coordinator to coordinate all the aspects of this project and preserve sustainability of patient partnership. We've also developed policies and procedure and now are embedded in our quality system. And finally, we've created the partnership culture within our organization. We've provided multiple trainings, brochures, and real patient partnership story experience to the public in order to increase awareness within our community. So as a conclusion, patient partners recruited by the objective eligibility criteria can actually be empowered, supported, and authorized, but balance is the key to preserve the beneficial outcomes for everyone. So patients and families were not only involved, rather we had developed a long-term professional partnership with our patients. Thank you.
Alaa, thank you so much for that. You were very good and very much within the timeline. Lhara Mullins is from Galway, and Lhara, like myself, was confused with all the CES time and the IS time and the Greenwich Mean Time and all the rest. So she was a little bit late coming into the warm-up session, and yet now she's going to open the whole session. So thank you, Lhara, and Lhara's going to do it live for us. So thank you, Lhara.
No problem. I'm just going to share my screen now. So good morning, everybody. I'm delighted to be presenting to you here from Galway virtually. I think it's really inclusive that we have this opportunity to present if we can't travel. So I'm really grateful to the conference committee for this opportunity. So my name is Dr. Lhara Mullins, and the title of my presentation is Engaging with Autistic Children and Their Families, Strategies for Effective Partnerships. So what I'm going to discuss with you today is initially I'm going to discuss, to give a bit of context and background, what is autism, and then I'm going to discuss autism and parenting and the significance of parent support and parent coping capacity to outcomes for the child or young person. Then we're going to look at a really realistic and tangible case study to explore what do families really need. Then we're going to discuss making every contact count, and we'll also consider effective versus ineffective practice. And this presentation today is based on my experience both as a social worker and as an academic in the professional capacity of supporting autistic students and families of autistic children, but more so based on my perspectives as a parent. So 3 of my 4 children are autistic, and I write extensively on this topic. So just to give a bit of context and background, in case you haven't heard about autism or don't know much about it, autism is a neurodevelopmental condition. And this condition varies significantly from one child to the next. So there's a really good saying online that was devised by autistic adults, and that it's if you've met one autistic person, you've met one autistic person. And what we mean by this is no 2 children or adults who are autistic will present with the same needs. So autism is being diagnosed much more frequently now, and we hear about this a lot in the media. And there was actually something on BBC this week and Undercover in relation to ADHD and you know, bot assessments, and you know, people have lots of different theories on why this is, but really the reason that autism is now being diagnosed more frequently is because we can see it and we can recognize it. So there absolutely was autistic people, adults and children 100 years ago. We just didn't recognize this or give the people the support and care and empowerment that they needed. So autism impacts the child or young person in relation to 4 specific areas. So the first area would be executive functioning. So for example, perhaps starting a task, knowing the different steps involved in a task and being able to finish a task. So that initiation and completion. It impacts the child or young person in relation to social and communication issues. So some autistic children, my own included, would be verbal. So they would have verbal skills and abilities, but they would absolutely struggle consistently in terms of communication ability and socializing with other people. And then probably one of the most consistent elements of autism across the board would be the need for sameness. So this is where routines, consistency, schedules, and knowing what to expect are really important for autistic children. And then finally, sensory processing. So this is how we interpret the world around us through sight, sound, smell, and touch. So for example, with autistic children, we commonly see sensory processing in relation to clothing and how clothing feels. So you'd often hear parents cutting the tags off clothes or having brand new clothes that are never worn because how they feel is really distressing for the child. So again, just to draw the 2 issues together, so to look at autism and parental coping capacity. So we need to look at what the research says around this. So parents of autistic children are more likely to experience stress, psychological distress, and depression. So this is what the research shows. Parents of autistic children are more likely to be unemployed due to their child's care needs. So this has a knock-on impact in terms of the 24/7 caring responsibility, but also in relation to the financial difficulties that this can present. Autistic children and their families are faced with increased social exclusion. So this may be due to challenging behaviour, but it's often due to stigma and the reaction of other people in society. And this can often be from family members as well, unfortunately, and culture can further contribute to negative stigma associated with an autism diagnosis. And then finally, parental fatigue and exhaustion. So this is impacted often by challenging behaviours, and this in turn impacts coping capacity. So if a parent is exhausted, their ability to parent is going to be decreased, or they may not be parenting the way they would if they weren't exhausted. So this actually can ignite or exacerbate challenging behaviour which is displayed from the child, which then in a loop effect again impacts the parent in terms of their coping ability, capacity, and their fatigue. Okay, so just looking at this case study here, and this is a really typical case study. So I do a lot of informal support work as we have massive wait lists for services for autistic children and families in Ireland. So as parents, there's a lot of peer support going on in the background. So Josh is a 6-year-old boy and he's been diagnosed as autistic, and this is after a 2-year wait for assessment. His speech is limited and he becomes frustrated, and this results in challenging behaviour. And sometimes this challenging behaviour can manifest and increase, and it can result in Josh lashing out and hitting and hurting his 2 younger siblings and his parents. Josh is also on a reduced timetable in school. So instead of going to school for 5 days a week, his timetable is reduced down to 2.5 days a week. And again, this is due to that challenging behaviour issue. Josh sleeps very little and he wakes up to 10 to 15 times every night. So regardless of the setting or sector you're in, when these parents come into you, this is what you're going to be presented with. Now, this could be while you're working in a school that you come into contact with this family, or it could be as an administrator in a hospital, or it could be in a community or in a medical setting, specifically for responding to families in need. Linda and Peter, Josh's parents, attend for their first appointment. Linda is crying and expresses that they're struggling to cope with Josh's needs and they're worried for the future. So this is what this family is presenting with initially. So now we're going to look at what do families really need. So oftentimes when we hear about waiting lists, we hear about families' need for therapies and needs for intervention such as speech and language therapy, occupational therapy, perhaps physiotherapy if there's another co-occurring condition alongside the autism. But really, what families really need is someone to really listen to them. And that's particularly significant for that first appointment. And it might not even be a first appointment. It could be a first interaction with a teacher at a school gate. It could be meeting another parent at a parents' morning. Sometimes people just need somebody to listen. And then the second thing that families really need is to work in partnership with somebody and to build that trust. So even if you don't have all the answers, or even if you can't get a therapy that a child, very much needs, and you can't get that to happen very quickly, if you are building partnership and trust with this family, then that is actually a really positive impact and intervention for their family. And then finally, lastly, but actually fundamentally the most important thing that families need when they present, looking for support and advice in relation to parenting autistic children, families need hope. So if we look at each of these just in a little bit more detail, so really important to note, and I remember this feeling very well myself, is fear. So when you're presenting for services and when we have children, we don't expect to have multiple different people contributing to our private family life, or that we'd have to ask for advice and support from professionals to just do our job as parents. So this can present a lot of fear. We fear being judged for needing help. We fear that we're not good enough, and we really fear for our child's future. So a lot of families would worry about what if something happened to the primary caregiver, who would look after their child. And then secondly, hope. So this is such a tiny word, but it has a massive impact. Parents can attend feeling hopeless. The waiting list, the lack of family support, and the lack of access to services can culminate into feelings of hopelessness. So instilling hope is crucial at each interaction. And then impact. So you will probably forget about this appointment, and you might have 5 more appointments that day, or 5 more parent-teacher meetings, or 5 more sets of parents to meet. But parents will remember every single word you said, and particularly at a first appointment or meeting. So your impact is substantial, and it will affect this family long after the meeting ends. So I still remember conversations from 15 years ago of things that professionals said, or advice or feedback that I got. So just, to be really mindful that your words are so powerful in this context. So then to look at the working in partnership. So oftentimes we can consider professionals and parents as us and them, or us and our service users, or us and our consumers or service owners, but it's not us and them, it's just us. So parents and professionals both have the same goals. So we're both working to maximize outcomes for the child or young person who's autistic, to support them in every setting that they're in, and enable them to reach their full potential. And really what we want more than anything else in the world, both professionals and parents, we want this child or young person to be happy. We don't want them to feel distressed, and we want them to have their needs met. So it takes a village to raise a child, and unfortunately some families just don't have this village. So in relation to the practice response, so first off, to listen. So to really listen and remain non-judgmental and supportive. So this means if a parent needs to speak and jumps from one topic to another, and does this for 30 minutes, they may not have had anybody else to listen to them in this context before, or they may not have had another space where they felt that they could share the difficulties that they're experiencing. Identify and prioritize the key needs of the family. So if we look at the example from the case study of Josh, so what jumped out to me from this case study was that sleep must be having a massive impact on every member of this family. If Josh is waking 10 to 15 times a night, this is going to contribute to the challenging behaviour. It's going to impact parental coping capacity and both parental and child well-being. And then examine the existing and potential support network. So again, back to the case study of Josh. Does this family have anybody who can help them informally? Is there a grandparent or an aunt or an uncle or somebody who can help? If they don't, what supports are available in their community that we could tap into? And then what formal or professional supports and referrals are needed? Okay, and then maximizing positive interactions. So just before we finish, some effective versus ineffective interaction examples. So a really effective and comprehensive method of promoting effective practice with neurodivergent children and their families is planning each meeting. So this means reading the previous notes. If it's a first meeting, looking at the referral forms, looking at all of the information that you have on this child and family, ensuring that you have sufficient time, planning what you will say. So again, going back to that every single word you say will be remembered by this family. And then ending on a positive or proactive note, which communicates hope. So this might say, between this meeting and the next meeting, I'm going to do X, Y, or Z, or I'm going to make contact with this person and we're going to try and get this moving. So to give them something to hold on to that they can take with them that communicates that things will get better and that you're actively working with them to make sure that that happens. An ineffective practice within interactions with families would be asking them what brings them to this appointment. You'd be really surprised by how many times that happens. So what brings you here? The question is really difficult if you haven't slept in 3 years and your child, you know, has been removed from a play centre for biting other children. It's a very frustrating question. Not reading notes and asking about previously provided information. So oftentimes at medical appointments, we give people the gist of things again, but if we have to explain the same thing again and again, that can communicate that the professional perhaps hasn't given my family or my child all of the care, attention and time that they need. Appearing distracted, uninterested or rushed. This appointment may have been 2 years in the making, so give it your absolute full attention. And then forgetting the child or the parents' names. I know it's very hard as a professional, we're juggling lots of caseloads. It's really important to remember what the child and the family's names are. So conclusion and takeaway points, supporting parents is supporting autistic children. Every interaction counts. Improving parental coping capacity results in improved outcomes for autistic children. Take the time to build trusting and supportive relationships with parents. Thanks.
All right, that was brilliant. All within time and everything. So deadly, like, you know, so well done, and thank you so much. You know, so that's really what we're aiming to do. So thank you so much, and we're going to hold now any questions. So please, if there's any questions, please put them in the live chat, and we'll hold them until the end of the session. Introduce Anna Riordan and Angela Morin, and they're both speaking to us from Canada, or near enough. Anne is just barely able to function, as she's not been able to do a crossword yet. They're up very early in the morning, and Angela tells me that she's on an island in the Thousand Islands, so it sounds really exotic, although it's got Canadian weather. So there you go, a bit like the Irish weather. So would really like to welcome the two speakers, and thank you very much if you want to carry on.
So I'm hoping that the slides will come through. Can you see the slides, Susan?
You look good, Anne.
Yes, we can. Yes, we can.
Great. Good morning, everyone. My name is Anna Riordan, and I am a patient experience advisor at Kingston Health Sciences Centre in Canada. That's a volunteer position at the hospital meant to improve the patient experience.
Hi, everyone. My name is Angela Morin. I am the lead for patient and family-centered care at Kingston Health Science Centre, supporting many of the patient advisors within our organization who are all people who've had an experience with Kingston Health Science Centre.
So our objectives today, we will share elements of patient engagement that led to a strengthened partnership during the pandemic, promote awareness of strategies to maintain family presence through patient leadership relationships, and we'll share lessons learned with a view to sustainability. Kingston is a small city of 140,000 people on the north shore of Lake Ontario. We are located on the traditional territories of the Anishinaabe and Haudenosaunee nations. On a journey of truth and reconciliation with our Indigenous peoples, we are thankful to share, learn, work, play, and grow on our lands. We are working together to build a new healthcare system that will be inclusive and equal for all.
Kingston Health Sciences Centre, KHSC, is southeastern Ontario's largest acute care academic and research hospital, consisting of our Hotel Dieu Hospital site and Kingston General Hospital site, as well as the Cancer Centre of Southeastern Ontario and 2 research institutes. We care for more than 500,000 patients and families from across our region, and we're fully affiliated with Queen's University. The Kingston General Hospital site provides complex acute and specialty care to people from across the region through its Kingston facility and 24 regional affiliate and satellite sites. The Hotel Dieu Hospital site is primarily an outpatient clinic setting, providing care to patients and families in the region through specialized programs and an urgent care center. It's also the home of Inunu Patient Services, which facilitates culturally safe healthcare services for Cree patients and their families from the northern and remote region of James Bay, some 1,300 kilometers to the north of Kingston. At KGH, the engagement of patients as partners began in what can be described as an organic fashion in 2009. The pool of advisors grew through word of mouth of early advisors, referral by program leaders, and from the patient relations program. Key to the engagement was creating opportunities to get involved and the need for the advisors to believe that their input was in fact welcome and would be used. Getting rid of restrictive visiting hours and introducing a family presence policy was one of the first tangible manifestations of that impact. Over the past decade, the engagement of patient and family advisors grew within the organization. Tools and education were created to support authentic engagement, and that partnership became embedded within the DNA of the organization at all levels. Organizational leaders are invested in patient and family-centered care. They model it, and they have built strong relationships with the patient advisors. There is no better example of that than what happened when a pandemic challenged our commitment to everything we had spent years building and to the fundamental pillar of patient and family-centered care, our family presence policy.
I want to share with you our story of setting the stage for patient engagement relating to family presence while preparing for the unknown of COVID-19. So please think back to 2020. Patient advisors initially heard about COVID concerns from hospital leadership at our monthly Patient Family Advisory Council meeting in February, when Elizabeth Barden, a hospital executive and our PFAC sponsor, alerted us to the potential seriousness of COVID spread and the need for a proactive plan. A number of us volunteered to join a COVID working group, and Elizabeth and Angela strategically planned a cross-section of advisor perspectives, from pediatrics and mental health to the regional cancer and renal programs. Our first meeting was on March 12th, the day after the WHO's pandemic declaration. The setting was a local cafe, Balzac's, as lockdown was looming with an escalation of pandemic concerns and restricted access. An overview of the emerging challenges regarding family presence was provided, with ample opportunity for questions and discussion. A congenial but focused atmosphere was created within the group. This early and proactive preparation created the groundwork for our engagement as COVID evolved. Our group developed a working together mindset and agreement to engage with speed and sensitivity. Elizabeth was our conduit to the COVID Incident Command Group, which met daily in the early days of the pandemic. This was the first and last time we met in person. We became known as the Balzac Group, and we have continued to connect and communicate for over 3 years to advise on the hospital's family presence policy. We last met 2 weeks ago, and our next meeting is tomorrow.
As the pandemic worsened, the trend for many organizations to restrict visitors and pause patient engagement strategies left patient partners, patients, caregivers, and families outside of the usual workings of healthcare institutions. KHSC moved in a different direction and included patient advisors in COVID preparedness and planning. Engagement opportunities and invitations expanded for patient advisors virtually. In addition to the 3 patient and family advisory councils continuing to meet, regular email updates, and invitations to town hall presentations, the Balzac's group became the go-to group for time-sensitive feedback and sensitive discussions about changes to the family presence policy. Adaptation of the family presence policy became an ongoing and fluid process. At the same time, new initiatives to mitigate some of the most difficult effects of limited family presence were co-designed by leadership and patient advisors and informed by staff and patient feedback. Recognizing the importance of family presence and families as partners in care, even and especially during a pandemic, was a high priority for the Balzac's group. Our voice ensured that this was never forgotten. We helped to highlight the needs of the most vulnerable populations we served and ensured the presence of loved ones for inpatients who were actively dying, people giving birth or having surgery or invasive procedures, pediatric patients, and patients whose care may not be safe without caregiver presence. For those who did not meet the criteria of vulnerability, programs were co-designed and resources put in place to support virtual presence, facilitated virtual visits, changes to cell phone access policy for inpatients in the mental health and addictions unit, gift shop deliveries, a care partner program, and an exceptions committee were all initiated through collaboration with the Balzac's group and included patient advisors in their review and design.
We examined family presence policies with an emphasis on clear communication, priorities, options, risks, flexibility, and expediency in our ongoing collaboration. What mattered most to me as a family and patient partner in this collaboration was transparency and the mutual honesty and compassion that grounded our recommendations. Our trust and respect for one another and for our viewpoints deepened throughout the pandemic. No one was happy about family presence limitations, but the Balzac's group ensured that every rationale for every change was warranted, limiting or broadening family presence, and that patient priorities were highlighted and communication to the public was transparent.
The collaboration with the Balzac's group and other patient advisors during the pandemic has reinforced KHSC's commitment to engaging patients and families at all levels of the organization, and there were structures, processes, and resources put in place that continue now and likely into the future. Co-designed initiatives that started during the pandemic are being incorporated into what is becoming the new normal. The model of the Balzac's group has been recognized as an effective way to engage advisors on complex and time-sensitive projects. Having this small group of advisors that bring various patient and caregiver perspectives, it's nimble and has the background and context to build on from the beginning has been tremendously valuable. The work that has grown from the collaboration continues to evolve, with a similar model being considered for the upcoming implementation of our new health information system and an interprofessional version of the ambulatory services program. The Balzac's group is now supporting the risk de-escalation process and review of the family presence policy. The Balzac's group shared concerns about how we would be supporting patients and families when restrictions on family presence began. The Staying Connected working group focused on ways that family members could continue to partner in care when not on site. A virtual visits program was one approach to address that concern. The response to facilitated virtual visits was so positive that the program has continued even with the easing of restrictions. Families who are at a distance or not able to come to the hospital can continue to request a virtual visit. Instructions on how to use the technology are provided. Hospital iPads can be used by the patient. Volunteers help with getting folks connected, or in cases of more sensitive or difficult conversations, will identify a social worker, clinician, or spiritual health care provider to assist. The Exceptions Committee was created in response to concerns about fairness and consistency in the decision-making process around exceptions to the family presence restrictions, and included a patient advisor with an equal voice in the decision-making. The committee continues to play a role in supporting staff as the family presence policy evolves. The Care Partner Program, initially created to support care partners to enter the hospital safely during COVID, has informed a new information booklet intended to provide guidance and support to visitors and care partners to share in the care of their loved one. A new Care Partner policy has been drafted, and the education and processes developed during the pandemic are being built upon the foundation of the Care Partner pilot project. In addition, with the removal of active screening and information services guide roles being piloted to support patients and families as they enter the hospital. The Care Partner and Balzac groups identified this support as a gap when the initial Care Partner program came to an end with the lifting of family presence restrictions. The influence of the Balzac's group was apparent in the hospital's exemplary status designation during our hospital-wide accreditation in 2022. The Balzac's group is a success story that continues to contribute to quality patient care.
We've shared a lot of information this morning, but we feel our lessons learned can be boiled down to these points. Through our pandemic experience, we learned that patient partnership and family presence are essential parts of integrated care and possible at all times through collaboration.
And there is no question that the pandemic challenged everything we had worked so long to build, and that mistakes were made. There were really hard decisions and lots of lessons hopefully learned. Being true to our commitment to the principles of patient and family-centered care, however, was always our North Star, and our foundation of patient engagement stood strong. I'm confident that there is no ignoring the power of collaboration with patients and families as we look to co-designing a more integrated, person-centered healthcare system.
And we're happy to share with you our resources and our contact information. Thank you so much.
And Angela, thank you so much for that. That's been very clear and a wonderful presentation. And we know that's happened all around the world, particularly during COVID, but it'd be interesting to see how we can go forward with it now in our questions. We might explore that a little bit. So thank you so much. I'm going to move on now. I'm wondering, Andrea, is it okay to present your slides? And Darren has said that he can show the slides if you don't have them, and you can talk to them if that's all right.
Yep, we should be good to go.
You good? You've sorted that, right? Okay, so
Yeah.
There you go. So welcome and thank you, Andrea, for this. And listen, technology is technology. It's still wonderful. We're talking to people from all around the world this morning, so well done. Thank you. Carry on there, and Andrea. Thank you.
Thank you very much. My name is Andrea Belanger, and I'm coming to you from Durham Region, Ontario, Canada, just outside of Toronto. I have the privilege of overseeing the family engagement team as my role as program manager, and you will see my entire team listed as co-authors of this presentation, as well as Michelle Lim, who was our coordinator for the evaluation. Next slide, please. Please take a moment to look at our belonging statement. And at Grandview Kids, we commit to actively promoting curiosity and incorporating principles of diversity, equity, and inclusion with our staff, volunteers, students, clients, and caregivers through education and honest dialogue. It is through these conversations that we commit to creating a culture of belonging for all. Next slide, please. Today, I will tell you a little bit about our organization, Grandview Kids, and the family engagement team that I manage. I will provide a summary of the evaluation methodology used to analyze the team's effectiveness and impact, share how lessons learned through integration of the family and caregiver voice past the point of consultation can be applied to all healthcare settings. Next slide, please. Meet our family engagement team, fondly called the FET. Grandview Kids is a center of excellence in pediatric care. Every year we provide family-centered pediatric and rehabilitation services to more than 10,000 children and youth with physical, communication, and developmental needs. An integral part of the interdisciplinary and family-centered approach at Grandview Kids is the inclusion of peer navigation through our family engagement team and our FET. To understand the evaluation methodology and recommended next steps we are reviewing today, we must first understand the scope and history of this team. Over the course of a decade, the family engagement team has grown to 8 peer navigators. We are parents of Grandview Kids, or were a Grandview client ourselves as a child. We call all our former clients grads. This team are paid staff who use their lived experience and specialized training to provide peer support, mentoring, and education to other clients and families. The family engagement team at Grandview Kids has surpassed 10 years of service to the families of Durham Region, propelling them as a sector leader in authentic client and caregiver engagement. Previous to this evaluation, the family engagement program had not undergone any formal evaluation to assess its strengths and identify areas of improvement. Next slide, please. So where did we begin for this evaluation? Let's start. Next slide, please. Our evaluation had 3 objectives: to increase the understanding of family engagement processes at Grandview Kids, to document the team's processes, progress, efficiency, and effectiveness in family engagement work, and to share lessons learned through evaluation, which we're accomplishing today. Next slide, please. The evaluation plan, its activities, the data, and findings were all guided by these umbrella of overarching questions. How was the family engagement team established? How does it operate? And what is the impact of the family engagement team on parents and caregivers? Next slide. The project embodied a participatory utilization-focused evaluation, often called the UFE, which means co-designing the evaluation questions and intended outcomes alongside multiple stakeholders within the organization. Methods were carefully selected based on the scope of the project. 2 evaluation types were applied, addressing 3 key areas. For our process evaluation, we asked, what happens in the family engagement program? What is the reach and uptake? To assess outcomes, we asked, how have clients changed from participation in the family engagement program? A series of group consultations with peer navigators and one-to-one interviews with the organization's senior leaders produced qualitative data. A digital whiteboard and verbatim transcripts aided in the development of a SWOT analysis, strengths, weakness, opportunities, and threats. An electronic survey was distributed to clients and caregivers. Next slide, please. We have consolidated the results into high-level takeaways with information on how our research can help others in their own program development. Next slide, please. Key insights from the evaluation can be broken into 2 categories, the family engagement journey and the function of the family engagement team. When examining team strengths, we found that as parents and caregivers or former clients themselves, the members fully understood the ups and downs, curveballs, as a partner in their child's care or their own journey. This is seen as invaluable to Grandview Kids, as well as the Durham region community. This is what led to the establishment of peer navigators at Grandview Kids, with the family engagement team growing from 2 to 8 staff in just 3 years. Team strengths also included creating opportunities to connect clients to one another in a safe and inclusive space, exceptional support for those within the team, and an ability to build strong relationships across Grandview to amplify the family voice. The evaluation also revealed the risks associated with the team's funding model, supported largely through grants and donations, which has not been consistent. There was recognition that this team is leading the sector, but also acknowledgement that additional work can be done to align with other leading practices for stakeholder engagement and advocacy. These findings underscore the value and benefit that lived experiences and peer support bring to a healthcare organization when you provide these types of services as part of an interdisciplinary team. But there is still emerging evidence around best practices for this type of work that Grandview Kids and others must continue to document, uncover, and spread. Next slide, please. When reflecting on challenges and gaps revealed in the evaluation, we learned the role and responsibility of the family engagement team can be unclear at Grandview Kids. There's potential cross-team duplication with other teams within Grandview Kids, specifically the organization's social work and intake teams. We heard that the family engagement team's overcommitment, which puts them at risk of burnout and empathy fatigue. Because of their passion and commitment to their roles, they always tend to say yes to any family in need, attempting to do it all when responding to requests for families or others within the organization. The evaluation also showed that the inability to track the family engagement team's work and quantify their efforts make it difficult to report on the team's long-term impact and on the organization and the clients and families they support. Next slide. Our comprehensive family engagement team evaluation yielded recommendations to continue improving this program at Grandview Kids. We have adapted these recommendations, focusing on strategies that could be replicated by others attempting to enhance their own similar program or begin to build one. First, be clear on the role of peer navigators and the family engagement team. Review, revise, and consolidate the scope of practice so all those within your organization understand both the value and purpose of the team. Aligning to leading practice methodologies for stakeholder engagement will encourage buy-in. Communicate the model, highlighting current responsibilities and specific program offerings. None of this is possible without first cultivating a culture where the family voice is embedded in decision-making and as part of the interdisciplinary model, something that took a decade at Grandview Kids, since we pioneered a lot of practices that have since been adopted by our sector partners. 2, equip your family engagement team with the skills they need to drive program innovations with measurable outcomes. For our team, this means refocusing on training and project management and ensuring the team has access to reliable client data, including tracking our own activities in the client health record, something we currently do not do, but is in the work plan for this year. Tracking the team's work in a quantifiable way is important for ongoing funding advocacy to ensure the program is sustainable for years to come. We also identified the need to provide additional training on mental wellness due to the risk of burnout in this type of work. And finally, we must continue to market this team and the incredible work that they do. Without promoting your family engagement team and their scope of services, success is limited. Ensuring there are strategies to engage a diverse group of clients and caregivers is important. For us, this means placing family engagement staff in all of our 8 office locations on a reoccurring basis, planning events for families that reflect the needs and diversity of geography, age, ethnicity, and other factors. These types of supports are needed and wanted, so make sure that people know how to access them within your community. Next slide. Like all studies of this kind, limitations or hurdles are expected. Limitations, which could be mitigated for others attempting to replicate, include the reliance on anecdotes versus quantitative data, low survey uptake, and gaps in gathering broader perspectives of the team's effectiveness within Grandview Kids. Next slide. To summarize 3 key takeaways and themes from today's presentation, lived experience is a valuable skill to integrate into interdisciplinary healthcare teams. 2, measuring family engagement team efforts and impact on clients and caregivers will ensure program sustainability. And number 3, leading practices for family engagement are still emerging. Next slide, please. Thank you very much. We've added our contact information, familyengagement@grandviewkids.ca, if you have any questions for us, or I will be here at the end should we have time. Thank you.
Thank you very much, Andrea. That was great. We will have time at the end to ask some questions. So we just have one more speaker, and that's Dr. Hayley Crooks. And Hayley's going to speak to us now. Hayley is in her other part of her life when she's not doing this work. She's a filmmaker, and she's going to let us all know when we're due to go to Hollywood with her. So because we knew her before she was famous. So so welcome, Hayley, and thank you for your presentation.
Thank you so much, Dr. Kent. So I'm going to go ahead and share, and hopefully these will work. Let's see. Okay. Can everyone see the slide there?
Yes.
Okay. Okay, perfect. Thank you.
Thank you.
All right. So good morning, or I suppose almost good afternoon, Belgium time. So thank you so much to the organizing committee, Dr. Kent for chairing this panel, and to all of my co-presenters today. These are really fantastic presentations. So I'm coming to you today from March of Dimes, Canada. We're Canada's largest community-based service provider for folks with a range of disabilities, as well as stroke survivors, senior citizens, and people experiencing post-polio syndrome. I'm a knowledge broker. I'm focused on client or service user engagement at March of Dimes, Canada. And if you caught Alana Armis's presentation in session 4.2, in that presentation, Alana offers a really broad overview of our organization, as well as the Empowering Client Voices initiative. But today, I'm going to focus on a discussion of our trauma-informed advisory committee and the work that we're doing co-designing a set of service user or community engagement principles for the purpose of transforming our very large organization. So according to the Belgian Federal Public Service, approximately 15% of the population in Belgium has a disability as of 2021. According to Stats Canada, 22% of the population of Canada, or 6.2 million people, report having at least one disability. So following the call from the disability justice movement, Nothing About Us Without Us, we're co-designing a set, as I said, of service user engagement principles through trauma-informed advisory committees. People with disabilities in Canada face significant challenges, including social exclusion, stigma, and poverty. As a result, many organizations, such as the ones that you've all been speaking about, are working to address these issues and create more inclusive communities. Today, we're going to be discussing how March of Dimes Canada is transforming its programming by putting service users at the center of decision-making. So we know that folks who have experienced injustice and stigma have a deep knowledge of the issues that shape our research and its commitments. We knew that intellectually, but we're learning in real time that when we work with and not about folks with disabilities, we can really create meaningful principles that are relevant and responsive to their lives. We believe in what Michelle Fine refers to as the right to research. Anyone who's going to be impacted by the research needs to be involved in it. The co-design work we're currently engaged in can be understood as what Maria Torre calls a participatory contact zone, because we bring very different knowledges to the table. We have service users, service providers, academics, all looking at the same case or problem issue. In this case, the absence of respect, dignity, and autonomy in everyday life, as reported by many of our community members. But we're looking at this from a bit of a new angle. So to answer this call, we're co-designing, like I said, these principles. We did a thorough review of the literature, a large environmental scan, comprehensive external and internal stakeholder engagement with other nonprofit organizations, whittled that down to 34 themes, and then we came back with 6 to work with our advisory committee on. The research team includes the Knowledge to Action team here at March of Dimes, which is the research department, a cross-functional team from across the organization, and 16 service users across generations and disabilities. Through the completion of this work, the study aims to have, like I said, a set of service engagement principles that's informed by and rooted in the voices of our community and based on the current literature and best practices. And we also need to make sure that these are flexible. We have a huge range of context and factors across our programs and services. So we're aiming to make these flexible so that we can engage continuously with our service users in a way that's person-centered and informed by best practices, but also able to make this grow across a very large national organization. We believe that this work is going to strengthen our service user participation and decision-making, as well as enhancing our capacity as an organization to really stand up these kind of continuous engagement practices. Co-designing community engagement principles involves working with service users to identify their needs and preferences, as many of you have discussed today. And this approach helps to create programs and services that are more accessible, relevant, and engaging for service users. This approach really, we're trying to break down the barrier of the power dynamic between our community of service users and creating a more equal relationship. So in the context of our diverse cross-disability advisory committee, trauma-informed really means creating an environment that is sensitive to the experiences of trauma and promotes healing and empowerment through active listening and amplifying their voices. Trauma-informed principles recognize that many people with disabilities have experienced trauma, such as daily systemic violence, which can impact their physical and mental health, as well as their ability to engage with services and systems. Trauma-informed care is best described, is based on a theoretical framework that emphasizes safety, trust, choice, collaboration, and empowerment. These principles are aligned with our co-design work at MODC on service user engagement, which places collaboration and empowerment at the center of everything that we're doing. So instead of continuing with the traditional route, I thought that the content of this talk would really lend itself to something a bit different. So I'm going to invite you into one of our advisory committee co-design meetings, and I'll take you through a scene from our project. So in our 2-hour co-design meetings, we strive to create a space that is safe, inclusive, and respectful of everyone's experiences and perspectives. We start each meeting by doing a group check-in where we check in with everyone's mood. This is the check-in we did at our last meeting. And this really helps to create a welcoming, affirming environment for people of different identities. And the check-in creates a space for folks to socialize, connect with peers, and it also allows us to build trust and get to know our members and be properly informed of each individual's energy level for the particular session. We also use accessible communication practices such as speaking clearly, using plain language, accessible font, and we provide different modes of communication. So if we need to have sign language interpretation. We always have live captioning to ensure that everyone can participate fully. And we have a communications disorder assistant present to support communication, annotate when needed, and make sure to minimize barriers. So we create a lot of space to add comments, to revise the work that we're doing. We share all of our drafts in Google Drive. We offer one-to-one support for folks that need that, as well as audio versions of all of our documents. We strive to make these meetings accessible for folks with aphasia, brain injury, and other barriers. So we include multiple choice and fill in the blank options for any of the more open-ended questions that we're trying to raise and unpack. And this is important since the types of open-ended questions we like to use for our co-design are often inaccessible for many. And we know that folks who have the most barriers are often the ones that we really need to hear from. So it's just an example of how we present some questions here. It's an example of some of our fill in the blank questions. And these slides are all from our second co-design meeting for our second principle called Relationship Partnership. In the first co-design meeting for this principle, like all principles, we did a deep dive into the topic, and we make sure that everyone has shared their experience and insights with the group. From there, we create a first draft and bring it back to the group for reflection and validation. So this is the formula that our committee created together when discussing how, as an organization, we can get to a place where users are feeling heard, respected, and included in an environment that wants them to be there and that supports their independence and all of the skills and abilities that they're bringing into our space. Empowering Client Voices Committee members, this is one member discussing how we can better support service users' decision-making by entering into partnership with the community that we serve. This quote is an excellent one for highlighting the themes that led to the creation of our relationship partnership principle. And it also kind of points us towards this broader theme that we're seeing come out of our work around really moving from relationship to partnership, as one of our community members described it. So the next three slides are ones that we brought to the committee at the beginning of the year to show them an overview of all the work that we've done together so far. And to use this slide, we use this each meeting to show them where in the co-design process we are regarding the 6 themes that we came up with. So just as a nice example of co-design here, we came to them with a potential title around ownership for this principle we're working on. But then someone said, well, how about partnership? And then another committee member said, I like relationship better. And then one of our committee members finally said, you know what, let's use a slash, relationship / partnership. So that's how we arrived at this title. It's kind of a nice example of co-design. So one way to understand how these co-design principles are trauma-informed is to look at the principles of trauma-informed care and how they align with our service user engagement principles. So you'll see that the priorities around safety, choice, trustworthiness, all of the sort of key core elements of trauma-informed best practices can be seen here in the 6 themes that our committee have co-designed together. So this is one way that as an organization, we're prioritizing lived experience in a conscious organizational effort to place our service users' voices and knowledge at the center of our transformation. So we always end each meeting with time for questions. Often folks will stay on the call later. Sometimes we'll arrange a one-to-one call with them or support folks, maybe even help them with their personal computer and their Zoom connectivity. As we've seen today, we all have things like that where we need help because so many folks point out barriers to navigating services and programming. We always make sure that they have at least 1 or 2 points of contact so they can reach us with any support that they need to ensure that their full participation is happening in the committee and in the important work that we're doing together. Finally, we close out by going over our next meeting time. Some folks like night before reminders for meetings. So we have large text, we have audio versions. And as I said, we have a shared drive where we can collaborate on our materials together. So I want to thank you for joining our Empowering Client Voices meeting. We were thrilled to have you join, and I look forward to sharing some more of the findings, hopefully connecting around similar projects. So just to wrap up, as we've seen, co-design with service users is a key strategy for operationalizing trauma-informed practices. We always keep our committee in the loop on progress that we're making with socializing and planning the implementation of our principles, and this is really, really key. We feel a huge debt to our committee members. They use a lot of time and energy to work with us on this, so we're very focused on keeping them in the loop on how we're actually moving this and mobilizing it from knowledge to action. And we're really engaging in authentic engagement, so it's quite a new territory. And we know that many nonprofits have successfully implemented similar projects, so we're feeling really excited and hopeful for the future. So thank you very much, and I really do hope to keep the conversation going. So many of you have presented such amazing presentations and so much food for thought. I see so many symmetries between what we're embarking on here and the amazing work that all of you are doing co-design. So I look forward to continuing this conversation. Thank you very much.
Thank you so much, Hayley. That was great. There is a common theme throughout all of them, obviously, and it is the fact that patient and family are what we hold central to everything that we do. I've worked myself for years on the community, and there's nothing like the community for reminding you that you're a guest in their lives. You know, when people come into the acute sector, into the hospital, or into the sort of a clinical space, it's very much the professional leads and all of this, and we can tend to forget, and we have done over the years, but thankfully now, with more research, with more approaches like this, we are remembering. And because we're all patients ourselves at some point, or we're all clients in our service, so we also know how we're spoken to by people who actually don't know that we're health professionals or whatever, right? So yes, I've spent years in the community where, not often, but you have the potential to be refused at the door, you know, sort of thing, and you are an invited guest into a person's house. And basically, if you don't do something correct on that first meeting with somebody, if you don't interact, if you don't demonstrate respect and all of the rest, you won't be getting a second invitation, and that's critical, you know, sort of thing. So look, we did talk about a few questions, you know, sort of earlier, and there is obviously technical issues going on, but there are a few questions that I wouldn't mind asking. I wanted to ask, like Lhara, I can't, I mean, the amount of work, you know, that you obviously do in your life, and both in your personal life and in your professional life, you know, sort of thing, you must have a great organizational structure in your head and in your life. And you did say that you were going to do some future research. Where is it that you want to take your research within autism, Lhara, going forward?
Yeah, so the area I feel most passionate about in terms of parental and family need, and subsequently then child need and child outcomes, is around peer support. So we're doing a lot of peer support in Ireland, but we're doing it informally. Whereas in the US, they have a fantastic network across 50 states called parent-to-parent or peer-to-peer support. So at the moment, I am working on a pilot project with our second largest disability service provider in Ireland, and we're going to introduce peer-to-peer support for parents of disabled children in Ireland, and hopefully do a piece of research on that. So we're almost at the recruitment stage now. So that's the first thing I'm working on. And then the second thing, I'm writing a book at the moment for professionals on how to create supportive environments and support autistic, ADHD and dyspraxic children and their families.
Oh, very good. I mean, I don't know where you get the time. You must do it in the nighttime when everybody's asleep. So well done. But I do know, certainly in autism, I'm not sure if it's the same for everybody in your own country, but in Ireland there seems to be there's not a standardization of services, you know, and the access to services is very topical in the news at the moment, both services for the under 5-year-old, but also for access to school, you know, supports within schools and that. I mean, is the peer-to-peer has that supported, say maybe in the America world, a standardization of services for children, the fact that there is a bigger peer-to-peer, is that where you would see this going?
No, unfortunately, this is probably 5 steps before that. But like some of my co-presenters discussed, this is almost like a family navigator, so somebody to help guide you.
Yeah.
But the most difficult question I get asked, Susan, is where do I go if I suspect that my child may be autistic and there isn't a clear answer? So of my 3 autistic children, we have 3 completely different routes. There is no standardized one door, and that's what eventually we need to be aiming towards. But I think parents are so desperate now just to get children in through any door that they can, and usually it's at that crisis point when children are seen, and it shouldn't have to get to that point.
No, and it shouldn't be late. It should be as early as possible, isn't that it, Jay? You know. Does anybody else want to add anything to Lara's piece?
I just wanted to make a comment and bless you for all the work that you do in bringing peer support, because that's my jam. That's what I love. I know here in Ontario with the Ontario Autism Program, there's Foundational Family Services, which supports some of the work that my peer navigators do. But unfortunately, you already have to have your diagnosis to get that support. And so we're seeing a bit of the same gap, that there's some things available, but it's after you've already taken all the steps, you did all the waiting, you get the diagnosis, you're 2 years into all your questioning, and the families are in crisis for not getting them at the very beginning. So I too wish that it could be much, much earlier in when people are saying, where do I go in the very beginning, and have some support at that level.
Interestingly, on that note, one of the criteria for inclusion was parents and families who are waitlisted, so they don't have to have a diagnosis. And this is why it's not going to be autism specific, it's going to be general disability. So once they're waitlisted, so this means that they've been identified as having a need for assessment. Now, even that can take 2 years to get to that point, but definitely we're not waiting until, you know, parents are well established. This is people who are really desperate and don't have any services or supports at the moment.
And Andrea, can I just add then, on top of that then, it was the question that you were highlighting, the challenges faced with over-engaging with families, because that seemed, you know, like there might be a point, like whether it's autism or the disability, that becomes the leading factor and the focus of a family, you know, where you're over-engaging, everybody's coming back to you because, you know, of this term that's applied to you for whatever term it is, like, you know, and also whether it's an older person or a younger person. So you say that there are challenges in relation to over engaging with families. Yeah,
absolutely. Those that are able engage, you want a great representation of everyone, and it's often those that are unable to engage that you really need to engage the most. So we do have a bit of an unbalance there.
It's the inverse law, isn't it? Those that need it the most aren't engaging. Yeah.
Absolutely. And then we're finding that those, you know, diehard families that are peer mentors, that are volunteering for panels, that are doing it all, and out of a need to give back often, they're overexerting, and we're really finding some, you know, compassion fatigue and overgiving. So how do we balance that? Because you never want to say no to a family that wants to engage, but how do we make sure that they're supported? So that's something we're really grappling with, removing barriers so everyone can participate, and also making sure those that are participating are super well supported so that they don't burn out as well. And that's an ongoing issue that hopefully we can all discuss for years to come, because we're probably all going to grapple with it.
Oh, okay. What about if we were to ask Anne and Angela an example of a co-decision making going forward? Yeah.
Yeah, I mean, I think it's an interesting conversation, Andrea, and we see that with advisors where people are just, it's hard to say no. And for years I started as a patient partner, patient advisor, and there would be so many interesting things to do, and you didn't want to say no, and you wanted to support. And so it is an ongoing challenge for those who are really passionate about this work. And what we're seeing a lot of too is how do we look at the infrastructures that we've created and the processes we've created to make them more accessible to hearing those other voices that maybe don't come forward in the way that, so we're doing lots on that as well. So interesting to hear that. And then for us, like during one of the examples that we shared during our presentation was around the exceptional healer or the exceptions committee. And what was really interesting about that is that the reason that started was because we were hearing from staff who were expressing sort of moral distress around some decision making, where the families that maybe wanted to come in didn't meet the criteria to come in during lockdown, and so we needed to come up with a mechanism to support the staff, and then so that came to the PFAC. And the PFAC, Patient Family Advisory Council, said, you know, there needs to be a way for those discussions to happen because there are going to be exceptions to every rule, and we need to facilitate that because our core values are that we will engage with family members and provide that access. And so there was a discussion about what that committee would look like. And then organizationally, they said, okay, but we need a patient on that committee. They need to be part of that discussion. It can't be just an organizational decision. And one of the patient advisors became part of that committee. And Anne, maybe you want to just build on what you see as the value of that.
What impressed me about the exceptions committee was that it was a small committee. There was a leadership representative, a clinical rep, the ethics person from the hospital, and a patient advisor. And they met at times on a daily basis. They were quickly responding to requests for exceptions to their family presence rule. And I know they had deep discussions, and the decision was made collaboratively. It wasn't left to leadership or to the clinician or to the ethics person. It was really made as a collective decision. And I think that's where there was an example of true power brokerage and power sharing with patient family advisors. I just found it was impressive. And they found a way to come to an agreement based on all of the factors that were presented. So
I do think though that can be challenging sometimes if you go back to what Andrea was saying, like, you know, where there's the same people in this space all of the time, so it's their voice that's really heard a lot, and you know, it might not be as collaborative as it appears. It might be, you know, strong personalities, I suppose, is really what I'm getting down to, you know. Yeah. How do you counter any of that?
Well, I think there are many times where I see the same people coming to the table. In one sense, the pandemic opened that up a bit more, in that people who were finding it difficult to get to the hospital where all of our meetings used to happen in person, they could now connect online if they had access to computers. Not everyone did, but we saw a lot more variety and diversity in our faces around the table during the pandemic, and more engagement from people who initially might have been reluctant. So I think that was one of the silver linings that happened during the pandemic. And have you
maintained that?
We have maintained that, and we've spread that. We're connecting with people across the country much more often. And in Canada, when it's so large, we seldom had that opportunity. And the virtual conferences is one way we've done that really successfully, I think.
Oh, very good, very good. Okay, can I just ask Alaa? Alaa, are you still there? Is Alaa still there? She might not be.
Hi.
Oh, Alaa, how are you? Thank you very much. You explained the project that you did very well, and it was very successful because of the participation of patients and families. I was just wondering, is there a way in which, have you demonstrated that transferring that same model into any other areas other than, you did it on hand washing? Was there any other, have you thought about putting it somewhere else now, you know, and engaging the people in that?
We're actually, it was during the pandemic, the COVID-19 pandemic. So we did actually engage some of the patients in the rural areas by using telecommunication devices So we did actually, some of the patient participated through WhatsApp video call. It is that simple. It's actually patient engagement is a belief that should be implemented rather than restricted by boundaries, let's say.
Yeah.
So we did
Yeah,
actually
that's
implement it in rural areas using
Yeah.
digital solutions.
And have you thought about moving? So like, I mean, that was great, and you did it for hand washing, hand hygiene. Are you going to look at any other initiatives?
Yeah, definitely. We are currently conducting multiple projects related to the patient engagement using the same methodology.
Yes.
Some of the patients were not able actually to attend the meeting, so we've adopted other methodologies by direct interview within at the bedside of the patient, by telephone communication, by surveys even. So we've maximized the patient engagement to ensure to cover all aspects of the patients or the groups, patient groups.
No, that's
So it
great.
is effective actually, and we are utilizing this project to multiple quality improvement projects within our organization, not just patient education or hand hygiene compliance and so on.
Very good. Thank you. Thank
You're
you,
welcome.
Anna. Yeah, thank you.
Thanks for you.
Thank you. Hayley, can I just ask you then finally what you see is the difference between the theory and practice when it comes to standing up the advocacy committee that you discussed?
Yeah, absolutely. Thank you. So one of the things that we're finding, and it really aligns with everything everyone's been talking about, but we had a vision of what this was going to look like. And then as we started working through these meetings, hope I pronounced this correctly, Laura, is that right?
Mm-hmm.
So all of Laura's findings essentially are what we learned during essentially our first couple of meetings was that, a lot of these folks really need connection. They need to be heard because, a lot of folks have not been heard and so the first 3 or 4 of our meetings folks were chatting. They were talking about their struggles, the barriers they're facing, systemic barriers, and that started to really inform the shape that our meetings were taking. So before we could get to our sort of co-design goals, we needed to just create a very safe and inclusive space, which seems really straightforward, but actually was a huge learning for us in terms of what this actually means in practice. And then our organization, we're 2,000 employees across the country, and we have many different service units. So we have some folks that have very strict regulations. They're government funded, not a lot we can kind of alter there. We have some programs where we can change a lot, do evaluation. So figuring out how we're going to actually implement these principles across a very wide range of practice contexts is really interesting to work through. And it means, just as I was saying, sort of bringing a really diverse group of stakeholders together to figure out how we're going to move it from theory to action. But the organization is very committed to it, so it's going to be an adventure. But it's a really great learning exercise. And also, just Laura, really quickly, my daughter is autistic, and everything you said resonates 100%. And sadly, we see the same things in Canada. With the patchwork of services from province to province, total lack of navigation, and a lot of our parents actually were doing a project called Best Start to Life with parents and young people. And they were talking about mental health, navigation, how these pieces kind of can't be separated. They inform each other. So I just wanted to say thank you for the work that you're doing, because obviously tremendously important.
And I think that's what I've learned too over the years. We always think that the rest of the world's doing something more than us. You know what I mean? Like, and that, we're all struggling with some of the same things. So it's great to be able to share them on this platform like this, Is there anything else that anybody wants to say that's burning before we finish? No. I've really enjoyed it. They're always great, these sessions, because you learn so much, the things that you don't know and you can refer back to. So it's all recorded as well. So you'll be able to get access to it as you are for the other sessions. What can I say? Only thank you so much for coming on and taking your time. And Anne's going to a crossword now anyway, for sure. So thank you, everybody. And thank you for coming on, and have a great day. Mind yourself. Take care. Bye-bye.
Thanks,
Bye-bye.
everybody.
Thanks, everybody.